Good evening, everyone. I am Dr. Zakaria Amash. I am a neurology consultant at Sheikh Shahood Medical City, and I will be moderating this webinar today. Welcome to you from everywhere. I know that you are coming from different countries, and we are very pleased to have you. It is today the third lecture. Welcome to the third Migraine Master Class. That's part of series of Migraine Master Class organized by IVPN NeuroPsychiatry with the collaboration of Pfizer and the American Association of Migraine Disorder. We are having two eminent lecturers today, Dr. Shivan Joshi from the USA and Dr. Ahmed Chetila from SSMC Abu Dhabi. I would like first to thank the support of Pfizer in contributing in our webinar today and the American Association of Migraine Disorder for endorsing this activity. We'll start our first lecture with Dr. Joshi. Good evening, Dr. Joshi, and welcome.
Thank you for having me.
Dr. Joshi is currently in private practice in Massachusetts, USA. He received his pharmacy degree from St. John University College in New York, and then he did an MD and received his MD from the St. George University School of Medicine, and he did his residency at Beit Israel Medical Center, his residency in neurology. Afterward, he went to Brigham and Women's Hospital and did the fellowship in headache, where he was on staff apparently afterward. He is a board certified in neurology and headache medicine. Dr. Joshi is a recipient of the American Headache Society 2012 Frontier in Headache Research Scholarship Award for Cluster Headache Research. Some of his clinical interests include trigeminal atomic valgia, such as cluster headache and migraine with aura in women. He is also a member in several professional medical societies, including the American Academy of Neurology and the American Headache Society. He is also one of the founding members of the Great Lake Regional Society and executive board member of the Association of Migraine Disorder. He is currently the chair of the Pharmacological and Therapeutic section of American Headache Society. Dr. Joshi is practicing currently at the Community Neuroscience Service in Massachusetts. Dr. Joshi, welcome. The floor is yours.
Thank you so much for having me here. I'm going to share my screen here. Okay. Okay, good. All right, you guys can see this okay?
Yes, yes, doctor. Yes,
Great.
doctor, go ahead.
Well, thank you for inviting me. It's a pleasure and an honor to be able to speak to such a wonderful audience of pharmacists, neurologists, residents. And we're here today to talk about a very important topic because there's so many advances in pharmacological therapy. I think we forget what we learned sometimes in medical school or residency, and the complexity of it, is very important to understand because it does matter to clinicians and patients. And I hope by the end of this discussion that you are able to agree with me that mechanism of action in migraine therapeutics is very important. These are my disclosures. So today, the objective is to review the mechanism of action of acute and preventive medications, newer and traditional medications, and understand the clinical implications. We're going to review the relevant pharmacokinetics of standard and newer classes of migraine preventive and acute medications, and then understand the potential for drug-drug interactions based on pharmacokinetic principles. So I'm going to sort of paint the picture with some epidemiology data here, okay? This data is from 2006 from the United States, but it gives you a perspective on what can happen if you have adverse drug events. And this is a big burden for patients as well as clinicians as well, and hospital systems and networks. So in an inpatient setting, the ADEs account for 1 in 3 hospital adverse events. 2 million hospital stays per year, and prolong the hospital stay by 1.7 to 4.6 days. And as you know, the longer you are in the hospital setting, the more costs associated with it. If you look at the outpatient setting, there are over 3.5 million office visits, 1 million ER visits, according to this data presented, and multiple hospitalizations. So there's huge amount of costs associated with adverse drug events. You know, when we talk about pharmacology, pharmacotherapeutics, there's also pharmacogenetics. I don't think that we are here completely advanced with pharmacogenetics yet. I think there's a lot of potential, a lot of research that still needs to be developed, but there are a lot of things that we do know about. You know, there are variations in enzyme inhibition, induction with individuals. There are several polymorphisms that may occur, and there are some patients that are ultra-sensitive. And I know you may see this in your practice, whether you are a neurologist, neuropsychiatrist, or even a pharmacist. You have some patients that are very sensitive to some medications, and some patients, they have no adverse reactions, and you need to go to much higher doses. So I do think that pharmacogenetics does play a role, but I still think that there's still more research that needs to be done in understanding this aspect of pharmacology. For example, when we look at the some of the metabolisms of enzymes, as we're aware, there are two different phases. The phase 1 is the oxidative phase, which involves cytochrome P450. For example, the CYP2C19 and 2D6 are very highly polymorphic. As an example of a medication, amitriptyline, very commonly used TCA medication, both for migraines, tension headaches, used for anxiety, mood disorder, multiple different uses for this. Undergoes demethylation to nortriptyline and then hydroxylation, right? And then there's phase 2, which is a conjugative phase. And why does this matter? Here's another example. Pharmacogenetics and psychiatry. If you look at clozapine, which is an atypical antipsychotic medication, there are a number of patients who experience agranulocytosis, which is one of the most severe adverse reactions on this medication. But in patients who had this marker, HLA-DQB1, versus in patients who did not have the marker, you can see the dramatic difference. So I present this just to illustrate that pharmacogenetics is something real and can play a clinical impact in patients' lives. Here's another example, trazodone. We use this for sleep. And if we look at the study, we can see that it has a higher clearance in women, okay? And there are some polymorphisms in the metabolisms of this medication, in particularly the ABCB1 influenced metabolism route. And when this occurs, there's a decrease in blood pressure and a prolongation of the QT interval, okay? Now, if you have a cytochrome P450-2D6 and ABCB1 mutation, there's also dizziness and prolonged QT prolongation as well, too. I also like to make a little side note about trazodone. When trazodone is metabolized, there's a metabolite of trazodone, which actually has been known to induce more migraines or make migraines worse. So sometimes higher doses can induce this separate from this pharmacogenetic principles. So this brings us to the question, and this is a very interesting question, and this is a great study that was used to highlight this. You have patients that have migraines, you have patients that don't have migraines. If we give them topiramate, right, who is more likely to have adverse reactions? So it turns out that same doses of topiramate were associated with different adverse reactions, and more so higher adverse reactions in patients with migraines versus patients who had epilepsy, okay? The migraine patients who had more reactions tended to be older, and there were more females and who did a slower titration. And this is important because it goes back to the pathophysiology understanding of migraine. Migraine is a hyperexcitable complex neurological disorder, right? Patients experience hyperacusia, sensitivity to light. So the brain is just hardwired differently, where you're more likely to have more adverse reactions versus someone else who does not have a migraine. So this is an interesting study where even if you have some benefit, patients are still less willing to take the medication due to potential for adverse reactions. And this is illustrated graphically here in this chart. The proportion of patients willing to take on the left versus the percent reduction of headache frequency on the right. And you can see this is beautifully illustrated that even though you do get some benefit, 75% here, you don't have as much patients willing to take the medication, and they may be due to adverse reactions. And since this is an international talk, I thought I would mention this in here. This is the report of counterfeit medications by therapeutic classes, which was reviewed by the World Health Organization. And you can see the multiple different classes here: antibiotics, other therapeutics, analgesic antipyretics, and as well as asthma and allergy medication. So there is some concern about where the patients are getting these medications as well too, if they are not prescribed and not obtained from a regulated pharmacy source. All right, let's do a quick overview for some of the pharmacists out there. This may be something simple for you, but I think for the juniors, this might be something very helpful to gain an understanding. When we look at the cytochrome P450 system, the CYP here notes the cytochrome. The 2, which is highlighted here, notes the family, right? So there's about less than 40% homology placed in separate families with this specific indication. The C notes the subfamily, and then the number at the end knows the individual enzymes. Now, this is important. If you look at the distribution of the major cytochrome P450 enzymes, majority are CYP3A4, 28%. But I want you to keep in mind this other metabolism here as well, too, because that plays, somewhat of a role in just our understanding of some of the newer medications. What are some factors that affect cytochrome P450 metabolism? So the dose, the route, the frequency all play an important role. Obviously, if you have a higher dose, you're going to saturate the pathways. Some orally administered medications undergo first pass hepatic metabolization. And there are genetic polymorphisms as well, too, right? Including certain ethnicities, such as Asians and Caucasians, may be higher metabolizers. Basic pharmacokinetic metabolism definitions. So a substrate is a medication that is metabolized by an enzyme, or a medication can be a substrate for multiple enzymes. There are enzyme inducers, as well as there are enzyme inhibitors. Okay, we're going to keep it as simple as this. So we look at other metabolism. There are 3 that come to mind, in particular because of recent advancements in the GPAD class of medications. They list these 3 other metabolism pathways in their package insert. So I thought, let's familiarize ourselves with them. The first one is the permeability glycoprotein, PG1. It's a membrane transport protein. Relevant substrates include atogepant, rimegepant, ubrogepant, topiramate, and verapamil. There's also breast cancer-resistant peptide, which is an efflux type of transport protein, similar to PG1. Relevant substrates include atogepant, rimegepant, ubrogepant. And there's also the organic anion transporter peptide, OATP, and substrates include atogepant. Now, just because they're metabolized through this pathway does not necessarily mean that it's clinically significant. So I think that this is important to know, only because the newer agents do have this listed in the package insert. It's something that we're generally not familiar with because we're more used to the cytochrome P450 route of metabolism. Now let's look at some general metabolism concerns, right? So grapefruit juice, right? So there are components within grapefruit called furanocoumarins. They inhibit cytochrome P450. They also inhibit P-glycoprotein, which can then enhance the bioavailability and reduce the P-glycoprotein substrates. Something to be aware of, there are some standard medications that are metabolized by this, including some calcium channel blockers like amlodipine and others as well too. Cigarette smoking, okay, very important. Cigarette smoking by itself is an enzyme inducer, okay. The carbon monoxide that comes out of the smoking is an enzyme inhibitor. It's very important to understand this. If you have some patients that are not getting some benefit and there are avid smokers, it could be that they're medication is being cleared faster. And as I mentioned earlier, there are some genetic polymorphisms as well. For example, P-glycoprotein expression is reduced in specific polymorphisms of Asians and Caucasians. Classic example of that is carbamazepine, right? So some patients who are of Asians have a difference in metabolism with carbamazepine. Now let's review some of the mechanisms, pharmacokinetic properties of migraine preventatives and the clinical implications. So we're going to go a little bit more in depth. All right, so these are the general class of medications we're going to take a look at. They happen to be more of the common classes of medications, and we'll look at some of the newer medications as well. First, when we look at beta blockers, these are very commonly used worldwide. However, there are numerous potential drug-drug interactions. You can see the enzymes that it belongs to, but I think of importance here is the one with rizatriptan. So if a patient is on a beta blocker, the rizatriptan dose will be doubled. Okay, so if you're using the 10 milligram dose, you might want to consider using a 5 milligram dose to prevent adverse reactions from the triptan, such as triptan-like effects, if someone is on propranolol. Another noteworthy adverse reaction is with metoprolol in someone who's on paroxetine, okay, or Paxil, because they both are modulated by the CYP2D6 system, and there's a possibility that your patient is complaining of or will have bradycardia. So this is something important to make note of. Now, when we look at the beta blockers, we also look at drug disease interactions too. So in diabetes, as you recall, beta blockers may mask or hide or cover the hypoglycemic effects. And so a patient could be hypoglycemic, but you might not realize this because it can be masked by the beta blocker effects. So this is something to be aware of. We know that beta blockers are also triggering COPD exacerbations, especially if they're non-selective, okay, such as propranolol, laetolol, versus the more selective beta blockers, which include metoprolol and atenolol. There's also increased risk of cardiovascular events, higher incidence of severe hypoglycemia as well too. When we look at depression and beta blockers, there are some reports out there that suggest that beta blockers can make depression worse. But in actuality, if you do a meta-analysis, it doesn't appear that this is actually real. But you might have some individual cases that you might be seeing this. There have been reports of depression that is worse in the elderly patients receiving more of the lipophilic beta blockers. Now, on the opposite side, we do tend to use beta blockers. And let's say you have a migraine patient that may have some anxiety component. So this is another area where you might want to use a beta blocker. Or let's say you have someone that has a tremor. And this is another place where we try to get something called a twofer, which is a dual effect, a migraine benefit and also a secondary benefit as well too. Now let's take a look at the anti-epileptic medications. Double Prox or Depakote. It's not really commonly used as a first-line preventive medication. It does have level A evidence according to the American Academy of Neurology and American Headache Society. However, we don't use this as a first line because of multiple potential adverse reactions. One of the primarily important one is that women of childbearing age should not be placed on this due to potential for teratogenic related effects. Right. Depakote is also used in IV formulations or in a short pulse mode to break headache cycles as well too. But as you can see here, that if you have a patient that's on certain enzyme inhibitors, such as aspirin or fluoxetine, or other medications, they may increase the dose of Depakote, leading to more adverse reactions and including hepatic-related effects. The more commonly used anti-epileptic medication is topiramate. Topiramate is only a weak inhibitor of the CYP2C19 and only a weak inducer of the CYP3A4. It's unlikely to interact with highly protein-bound medications, and some of the substrates for topiramate include amitriptyline as well as verapamil. Okay. Now, clinical considerations include if someone is on a highly protein-bound medication, right? So these include warfarin, okay, or others which have sulfa. This can be displaced as well too. When you have a patient that is placed on topiramate, there is a warning in the package insert that higher doses, around 200 milligrams a day, will decrease the effectiveness of the birth control, in particular birth control containing ethinyl estradiol. So obviously we don't want any unplanned pregnancies in patients, and you do want to make them aware that there is this potential interaction. Now, you may have patients that are diabetics receiving metformin. You may also have patients that are receiving metformin for other related symptoms, such as sometimes other fatty liver related or obesity related indications. But remember, the combination of both metformin and topiramate can lead to lactic acidosis, not to mention potassium related decreases as well too. So something you want to monitor for. All right, let's look at one of the other common medications prescribed. Amitriptyline is metabolized by 2C19. Of note, 2C19 is also very highly variable in terms of a patient's genetics. So there are people who are rapid metabolizers, and there are people who are very slow metabolizers. And obviously, if they're rapid metabolizers, they're not going to have the benefit. And if they're very slow, they're going to have more of the adverse reactions. There's concomitant use with SSRIs can lead to QT prolongation or anticholinergic toxicity. You want to be careful in elderly patients when using amitriptyline due to urinary retention as well too. Okay, there may be some risk of anticoagulation and hemorrhagic risk with use in someone with warfarin as well too. All right, so there's other interactions listed here. If we look at the other TCAs and the SNRIs that are commonly used in migraines, they include nortriptyline and venlafaxine as well, which are metabolized by the 2D6 route versus 2C19. Let's take a look at verapamil more closely. The verapamil is not really a first or second line medication for migraines. Nevertheless, it is used. It does have a level C indication, but we might be using this more as a first line for prevention in cluster headache patients, correct? So the verapamil is modulated by the P-glycoprotein pathway. There are some common drug interactions, but you should be careful in combining it with beta blockers because you can get cardiovascular depression as well too. In rare instances, you may also exacerbate myasthenia or induce myasthenia crises in patients that are placed on verapamil. Okay. A very important clinical note is that if you do have a cluster headache patient and you are increasing the dose on verapamil, very important to, let's say after 120 milligrams of verapamil, to obtain a baseline EKG before you advance to higher doses to make sure there are no issues. Again, for the patient, verapamil at higher doses can also cause more constipation as well too, and sometimes peripheral edema. I have rarely seen verapamil also cause elevated prolactin levels as well too, which is more on the rare side. Now let's, before we talk about some of the newer agents, let's do a flashback. So one of the first GPAD class of medication was talcagipad. It was developed by Merck. It was a very effective medication, very good efficacy data, but it resulted in some hepatic side effects, okay? And part of the reason why it developed hepatic side effect was that it was the molecule was not only targeting CGRP specific for migraine, but it was also targeting extrahepatic or other receptors as well, leading to adverse reactions. And the theory behind it is that it has to do with this phenyl glycosyl precursor, which was found in the original molecule, versus the newer molecules do not contain this phenyl glycosyl precursor, as noted here, ubrogepant as well as atogepant. Now, this information here is basically taken out of the package insert of these medications. Now, I bring this up because, this is a newer sort of area of metabolism that we're not familiar with. And so I want to emphasize that, these are the statements made in the package insert and the FDA. There are recommendations. Now, the clinical significance of this still has to be determined, but I'll show you some more updated slides that may address some of the clinical concerns or lack of concern with some of the data mentioned here. For example, When we look at ubrogepant, the metabolism pathway is CYP3A4 P-glycoprotein. Inhibitors, if you have someone that's on a strong inhibitor, such as ketoconazole, itraconazole, or clarithromycin, you may not want to use this according to the product label. Moderate inhibitors, the recommendation is dose adjustment. And then weak inhibitors, no dose adjustment is needed. Now, if you have a strong inducer, you want to avoid taking this medication. Some of the strong inducers include phenytoin, barbiturates, and St. John's wort. So St. John's wort is marketed in the United States. It's a over-the-counter medication. It's a herbal medication, primarily used to treat depression, but it actually has a line of P450 enzyme induction abnormalities. So it's something to be aware of. So if someone has a moderate or weak inducer, dose adjustment is recommended. Now, when we look at rimegepant, which is indicated both for acute and prevention, it's metabolized to a lesser extent 2C9, primarily 3A4. The recommendations include with strong inhibitors to avoid a second dose until 48 hours for moderate inhibitors, and avoid use in strong or moderate inducers. Both of these substrates, both of these medications are substrates of P-glycoprotein and BCRP, and increased exposure to GPANs with PG and BCRP inhibitors recommendation is to avoid. But I'm going to show you some data in subsequent slides that has been done post marketing. Some of the substrates for PG and BCRP include verapamil, itraconazole, and some of the other medications listed here, including carbidiol as well too, and curcumin. This is again taken from the package insert, atogepant. The recommendations are to adjust the dosing based on the inhibitors. So 10 milligrams for strong CYP3A4 inhibitors, 30 or 60 for strong or moderate. And if you have an OATP inhibitor, 10 milligrams or 30 milligrams once daily. Now let's take a look at some of this data that's presented here. So you have, this is presented at the American Headache Society in 2021 as a virtual poster in their annual meeting. The effect of strong PGP and BCRP inhibition using cyclosporin and quinidine on the pharmacokinetics of oral rimegepant in healthy subjects. So the data is shown here, but in terms of the interpretation of this data and conclusion, so the authors felt that the strong PG inhibitors such as cyclosporin and quinidine moderately increased rimegepant exposure, less than twofold. Rimegepant was safe and well tolerated. The moderate effects of rimegepant exposure may be generalized to other strong P-glycoprotein inhibitors. The similar effect of cyclosporin and quinidine on rimegepant exposure suggests that BCRP inhibition has minimal influence on rimegepant exposure. Okay, so important to know. Now let's take a look at another recent study that was published in Breastfeed Medical Journal in March of 2022. And basically, they wanted to investigate whether rimegepant, an oral small molecule calcitonin gene-related peptide, which you'll learn about in more detail in the next lecture to come, if it's excreted in human milk after a single dose of 75 milligrams. And then they wanted to characterize the concentration. So when they did this analysis, they found that on a weight-adjusted basis, the relative infant dose of rimegepant was less than 1% of the maternal dose. So here's the data showing you breast milk versus the plasma concentration in the infant, and it was found to be less than 1%. Now, let's take a look at the evaluation and pharmacokinetic interactions when we look at atogepant co-administered with topiramate. So on the left, we look at the concentrations of atogepant. On the right, we look at the concentrations of topiramate. And the purpose of this is to see if there was a change in the concentration when both of these medications were taken together. So atogepant plasma concentrations were marginally lower upon concomitant use of topiramate, which is a mild inducer of CYP3A4. And the topiramate concentrations were only marginally lower when used concomitant with atogepant. Here's another more recent study, published very recently, actually. It was a phase 1b open label study looking at a drug-drug interaction potential and safety between atogepant and ubrogepant. This was a study done by Dr. Blumenfeld and other authors as well. So single dose of ubrogepant had no statistical significant effect on atogepant pharmacokinetics. In fact, administering both of them together resulted in 19% increase in the ubrogepant area under the curve and concentration curve, and 26% increase in the ubro maximum plasma concentration. So the statistical significant changes in the ubrogepant exposure were not clinically meaningful, okay? So there was no new safety concerns that were identified for this combination. Now, let's take a look at the other class of medications, monoclonal antibodies. And as you recall, the monoclonal antibodies are not metabolized by your cytochrome P450 system. Instead, they are metabolized by your reticuloendothelial, which is also known as the mononuclear phagocytic system. There are specific target-mediated clearance and also non-specific elimination mechanisms that occur parallel, right? So basically, it's broken down into individual amino acids, and it just goes away. So here's another specific study that looked at the erenumab, which is a monoclonal antibody. They looked at combined oral contraceptives, ethinyl estradiol, and showed no clinically relevant drug-drug interactions. In addition, at standard doses, antibody-antibody interactions is also unlikely, since IgG clearance is dependent on the FcRn saturation, which is unlikely to occur at typical therapeutic doses of the monoclonal antibodies. Now, acute medications, which you're familiar, come in multiple different forms. They come in tablets, nasal spray, injections, and some parts of the world, they also come in suppositories as well. So here are the classical oral triptans. These have all been marketed throughout the years. The sumatriptan was the first one. We do like to exploit some of the differences between these medications and take advantage of them. For example, formotriptan has a long half-life. So we sometimes use that for menstrual-associated migraine as a premenstrual preventive indication. Naratriptan itself also has a second longest half-life. And we may use this as a menstrual migraine prevention as well. Sometimes we like to use this twice a day, 2 days before the actual start of the menstruation, and you continue it into the menstrual cycle. Sumatriptan has been around the longest. It has a very poor oral bioavailability, and it also has a short half-life, and sometimes this is leading to rebound headache. There are also certain anti-inflammatory medications. The diclofenac oral solution has been approved for FDA. They have 2 randomized double-blinded placebo-controlled trials. It is not marketed by the company in a brand form, but it is something that is available still. There's also ibuprofen and naproxen, and there's also celecoxib, which is a COX-2 specific inhibitor, was also marketed in the US as a solution. This is no longer actively marketed as far as I know, but this was a recent change. Important things to know that are important to patients and clinicians is that the triptan package insert still carries a warning for hemiplegic migraine. Now there's some debate about that because we have a better understanding of migraines now, that migraines are not as much of a vascular condition, more of a neuroinflammatory condition that involves CGRP, and more of a neurovascular component where vasodilation is not a main mechanism of action. So again, but the product label still indicates migraine with brainstem aura, which is the old terminology. The newer terminology is basilar migraines, where there still is a contraindications. Obviously, we don't like to use triptans in someone who has uncontrolled hypertension. Concomitant use with MAO inhibitors has been not recommended. Also, you should not use within 24 hours of ergotamine, because the ergotamine also potentiates multiple different serotonin receptors. You don't want to trigger a serotonin syndrome. It is pregnancy category C, but that's the old sort of nomenclature. The newer nomenclature, the United States, we don't use pregnancy categories anymore, but the package insert presents data and leaves it up to the clinician to determine if this is safe. Now, there are several articles that have been published which look at the use of sumatriptan throughout during pregnancy without having any significant difference between any adverse reactions if they didn't use sumatriptan or with other agents. So there are some pregnancy registry data that has been published where it suggests that this can be used in your pregnant patients. Again, contraindications, ischemic heart disease. But not only that, if you have multiple risk factors, let's say you do have controlled hypertension, controlled diabetes, controlled hyperlipidemia, and you have maybe sleep apnea, you're morbidly obese, I would still use caution in those patients who have multiple risk factors for coronary artery disease. Now, let's take a look at the new generation of medications. Rimegepant, ubrogepant, we've discussed already. I'm going to take a brief moment, only a few more slides left, to talk about lasmiditan, dihydroergotamine nasal spray, and sumatriptan nasal as well. And in the future, there is in development a zavegepant, which is intranasal gepant, which is the first and only intranasal gepant in development. But I do not have any detailed data to share with you at this time. But this is in development. So let's take a look at lasmiditan. So lasmiditan is a new class of medications that belong to medications called the ditans. It has a very high affinity, highly selective to bind to the 5-HT1F receptor, and it acts on the trigeminal system without causing any vasoconstriction, okay? Because it does not bind to the 5-HT1B receptor. As you recall, the triptans typically bind the 5-HT1B and D receptor, which are also found in cardiac tissue and cardiac blood vessels as well. So lasmiditan does not do this. It's indicated for the acute treatment of migraines with or without aura. It has good data showing you efficacy versus placebo. There is a warning in the package insert recommending not driving for 8 hours after use because there may be a potential for dizziness as well. So let's take a look at why this is unique, okay? So we look at the pathophysiology of migraines. We know that there involves the trigeminal vascular system, okay? And there's also these trigeminal cervical complex. So what happens is you have afferent impulses that release CGRP. Those impulses then go to the trigeminal ganglion, okay? And then from the trigeminal ganglion, remember the trigeminal ganglion is outside the blood-brain barrier. The trigeminal ganglion has pseudo-unipolar neurons that connect into the brainstem here. And the brainstem, they connect with the trigeminal nucleus caudalis, which not only receives input from the peripheral nervous system, it also receives input from the C1 and C2. And the combination of the trigeminal ganglion, the trigeminal nucleus caudalis, and the C1, C2 nerve input form something called the trigeminal cervical complex. At this point, signals go to higher parts of the brain. They go to the hypothalamus, thalamus, cortex, and also there's a descending pathway as well too. Now, what's important to note here is that the 1F receptor is found both in the peripheral nervous system as well as the central nervous system. So in this section over here on the bottom where I indicate E, the 1F receptor is found in the cortex, in the brainstem, the trigeminal ganglion, the cerebellum, higher parts of the hypothalamus as well. And this is the target where the 1F receptor is targeted by lasmiditan. So lasmiditan works by theoretically inhibiting the 1F receptor both peripherally and centrally. And as you're aware, the migraine pathophysiology involves both peripheral and central sensitization. The peripheral sensitization leads to the throbbing pain component, whereas the central sensitization is the part where patients complain about allodynia. Okay. All right, dihydroergotamine nasal spray. Now, we are familiar with DHE as an IV formulation. However, this is not practical and is associated with many different adverse reactions in patients. So There has been a different formulation available on the market, but there have been issues with effectiveness as well as availability of getting the medication to the right site. So what happened here was that this company developed this precision olfactory delivery device, which allows it to be absorbed with 1/10 of the Cmax of IV DHE, but yet IV-like plasma concentrations from 20 minutes on. So you're getting good efficacy with a lower dose. Important things to know, as you know, DHE targets agonistically multiple different receptors, including multiple different serotonin receptors, and as well as antagonist activity at multiple different other receptors, including dopamine receptors as well, too. So there is a cardiovascular warning. The package insert does suggest that before starting a patient to consider EKG as a baseline in patients. The other important thing to know is that you should space this medication 24 hours apart from any triptans if your patients are using both this medication and a triptan. Now, here is the difference between a typical nasal spray, which delivers the medication primarily to the lower part of the nasal mucosa here, but you have three different sections, lower, middle, and upper section here. The upper section is very rich in the vasculature. So you have the posterior ethmoidal artery, the sphenopalatine artery, and this is where the medication is absorbed. So using this technology, this pod technology, it delivers the medication in a plume, which reaches the upper nasal passageway, preventing more non-specific absorption as well, too. So that is the technology of this medication delivering DHE. Now, there is also another nasal spray. Now, this is the DFN-02. It's a sumatriptan nasal spray. What's unique about this nasal spray is that it delivers sumatriptan, but it's combined with a permeation enhancer. Okay, so this permeation enhancer, when it opens the gap junctions in the membranes in the nasal mucosa, when these gap junctions are open, the medication is better absorbed. So you're getting less amount of sumatriptan, but you're getting absorbed effectively. So you don't get the adverse reactions of higher doses of sumatriptan when they're used. So this is used for acute treatment of migraines. And you can see the data here showing you 2-hour pain freedom to be 43% versus 20% placebo. Now here's some pharmacokinetic data showing you the curves here regarding absorption. Your standard Imitrex nasal spray, you can see the absorption is very poor. Not to mention that it has a very burning-like sensation. And most patients won't like you if you give this to them because of the burning sensation, versus the sumatriptan nasal medication spray. You can see it reaches peak plasma in a short period of time, and this is where the effectiveness of the medication takes place. The goal is to get the medication absorbed effectively, and a lower dose allows you to do that without having side effects from higher medication side effects, higher doses.
5 minutes.
All right. So in conclusion, here are some important takeaway points. The mechanism of action does matter for both clinicians and patients. Drug-drug interactions are important to consider in patients who use migraine preventive polytherapy. I mean, you know it, we have patients that are on topiramate, a TCA, a beta blocker. And sometimes you have to think about the combination of all this and streamline, right? So polypharmacy is something that we always strive to reduce in all of our patients. So some consideration should be taken when you think about metabolism through the CYP3A4 system. I'm sorry, the CYP450, of which the CYP3A4 is the most common one. And when you tailor your clinical management, you can reduce drug-drug interactions, hospitalizations, adverse events in patients with comorbid conditions. So the newer generations of therapy, which I pointed out, may certainly be a safer choice and a better tolerated options for some patients. Something to consider as a whole when you think about your migraine patients. So thank you so much for your attention. I appreciate being able to convey this information to this audience. And I believe we're going to be moving on to the next presentation. I'll be happy to field any questions in the general question and answer session. Thank you.
Thank you for this nice lecture. It was very informative. Thank you very much. Dr. Joshi, please stay with us. We'll be having a session of question and answer after Dr. Shatila talk. For the participants who are present, please, you can send us your question and answer, and at the end of Dr. Shatila talk, we will be answering to all your questions. The next speaker is a colleague and a friend, Dr. Ahmed Shatila. Ahmed is a neurology consultant at Sheikh Shakhbout Medical City. He got his BS from Wayne University, his MD in Wayne University, and fellowship and neurology residency. I mean, also it was at Wayne University. He is currently the head of the multiple sclerosis clinic at Sheikh Shakhbout Medical City, but he is also the chairman of the medical advisory board, the national advisory board in UAE. Ahmed will be talking about the role of rimageptan and the efficacy and the safety of this medicine. Hello, Ahmed, the floor is yours.
Thank you, Dr. Zakaria, for the very kind introduction. First of all, I'd like to thank IVPN for the invitation to speak today. I would like to thank the audience. Without your support, none of these events could ever happen. And I would like to thank Pfizer for sponsoring this symposium. Let me move some of these tabs around so the screen gets busy. Let's see, how do I close this? Optimize? No. Hide. No, okay. One more. There we go. That's what I want to do. Okay. Can you hear me well?
Yes.
Okay. So turn on the microphone. Okay, there we go. So today I'm going to be talking, today I have a symposium sponsored by Pfizer about Nurtec ODT or rimagepant, one solution for many migraines, and the role of rimagepant. Here are my disclosures. So when we think about migraine, there are various unmet needs that we associate with the traditional acute treatments. If you think about the acute treatments, as Dr. Joshi had already nicely described and talked to us about, there are many issues. You got to worry about tolerability. And up to 40% of patients will experience adverse events within the first 48 hours, 24 hours. You got to worry about recurrence. Almost 67% to 82% of patients will have a return to pain within 24 hours. Medication overuse headaches. We routinely see this. Overuse of many traditional acute therapies can cause MOH, whether they're taking NSAIDs to stop the migraines, or they're taking triptans, or on more than 15 days a month can actually cause medication overuse headaches. And then you got to worry about the contraindications, whether it's medication adverse events, cardiovascular events, or hepatic events. So all of these we have to keep in mind when we're trying to choose medicine and avoid other problems. Now you can offer your patients the power of one medication to treat and prevent migraines. Nurtec ODT or rimagepant is actually approved as a preventive therapy of episodic migraines, and it's actually used as also approved as an abortive therapy for acute migraine attacks. Now I'm going to talk about the pivotal phase 3 trials for acute treatment. Rimagepant has undergone several phase 3 trials to test its efficacy and safety as an acute migraine treatment. You've got the phase 3 study 301, you've got the phase 3 study 302, and the phase 3 study 303. All in all, you have around 1,466 patients. So I'm going to talk first about the study 303, rimagepant 75 milligrams ODT for the treatment of acute migraines. So if you look at the study design, this was rimagepant versus placebo. Eligibility criteria, you had to be 18 years and older, 1 year history of migraine with or without aura, and you had to have onset before age of 50. After age of 50, we start thinking about other disorders. Greater than 2 or less than 8 headache day greater than 2 or less than 8 migraine attacks per month of moderate to severe intensity. This places you in the episodic range. Less than 15 days a month in the past 3 months with migraine or non-migraine headaches. Again, the definition, more than 15 days is chronic migraine, less than 15 days is episodic. So this was studied for episodic migraines. And then the patients were divided 1-to-1 versus rimegepant and placebo. And what were we looking for? We were looking for pain freedom and symptoms, phonophobia, or nausea, whether we were able to reduce it or stop it. Are those sort of the co-primary efficacy, freedom of pain at 2 hours, freedom of the most bothersome symptom at 2 hours, and then we had 21 secondary endpoints, which were broken down into 3 categories. Early action, 60 to 90 minutes, 2-hour effect, durable effect, and 2 to 24 and 2 to 48 hours. And then finally, safety and tolerability. So we'll first go with the first slide. Rimegepant did meet its primary endpoint of a significantly greater proportion of patients being free from pain and most bothersome symptom at 2 hours post-dose versus placebo. Now, if you look at the, I don't know, what is that, like purple? Dark blue, purple. If you look at freedom of most bothersome symptom at 2 hours, there is a significantly higher group of patients on the rimegepant group who were free of the symptom versus the placebo. If you look at freedom from pain, it's actually double. The patients were free from pain at 2 hours versus placebo. When you look at the treatment, when I told you the 21 endpoints, this is the overall quality of life as well as different aspects of efficacy. There were 21 points. 19 of the 21 were met with rimegepant. And as I told you, they were divided into 3 categories: early onset, 2-hour effect, and the durable effect. Now, if you notice, the only 2 that did not meet were freedom from nausea, which is on the bottom. You can see the freedom from nausea, that's at the 2-hour post-dose, as well as the no pain relapse. All the other endpoints were met, whether they were pain relief, ability to function, most bothersome symptom relief, freedom from pain, sustained efficacy, sustained freedom of most bothersome symptom, and sustained ability to function normally, or freedom from pain. These are all important things, and these are only just 4 or 5 out of the 19. So it actually met most of their criteria, which overall relates to better quality of life for our patients. Better quality, not just early, but better quality sustained and lasting a long time. When we look at the pooled efficacy based on previous triptan response, now if you were able to break down the patients who are the triptan naive, the people that were currently on triptan use, history of treatment failure of 1 triptan, and treatment failure of 2 triptan. It did not matter whether you were naive, you used triptans, you failed a triptan, or you failed more than 1 triptan. Rimegepant actually worked, and actually interesting, you can actually see the efficacy maintained very similar in whatever group you were looking at, whether you're looking at the pain freedom or the most bothersome symptom. So actually, this works for all types of migraine patients, whether you're naive, you're on a triptan, or you've actually failed a triptan. Rimegepant is a suitable alternative because it has a different mechanism of action. It works on the CGRP antagonist. It doesn't work on serotonin. Rimegepant 75 milligrams ODT for the acute treatment of migraine. The most common adverse event of rimegepant in the placebo was nausea. Around 2% of patients receiving rimegepant did get nausea and urinary tract infections. Now, the nausea is a little interesting because we know that patients with migraines will also get nausea. So it's hard to say, is the nausea really from the rimegepant, or is it from just one of the classifications of migraines? Because you actually, as part of the classification or the diagnostic criteria is that you have to have nausea or vomiting. Acute treatment unmet needs. When we look at the unmet needs, 25% of people who have migraines, based on percentage patients who consult a healthcare provider and are diagnosed with migraine, receive a migraine-specific treatment. So only 1/4 of those patients, and they're actually inadequately treated, or they discontinue treatment or are contraindicated for triptans. 37% of patients, although triptans are recommended as a first-line pharmacotherapy for acute treatment of moderate to severe migraine, only 37% of patients actually receive a triptan. And then if you look at the last one, 23.8, epidemiological research shows that around a quarter of patients or adults with migraines are eligible to be treated with novel acute medication. Nurtec has been shown to reduce pain and disability associated with migraine. Now, when we look at people and this an illustration right here, 55, so you've got basically, for more than 20 years, the triptans have been recommended as first-line therapy. There's been largely an unmet need for additional treatment options for millions of patients with migraine not eligible for triptan use. 55% and 81%. So if you look at 55.2% of people who do not respond to migraines, or do not respond to triptans, if you break it down, 40% of them don't respond or stop it due to adverse events, 33% stop it due to lack of response, and 27% stop it due to cardiovascular contraindications. Medication overuse headache. This is a very common phenomenon we see in our clinics. Now, medication overuse headache, unfortunately, it's a man-made problem. It's actually, well, migraines is you can't control who's going to get migraines, and you can't control your genetics. Most of the time, medication overuse headaches are a result of being treated for your headaches. You're either taking too many NSAIDs. You know, when I was taught, if you're taking more than 6 NSAIDs a week, you're at risk for medication overuse. And, you know, where I was trained, we were a little bit more conservative. We used to say 6, if you're taking more than 6 triptans a month, you're at risk for medication overuse headaches. So medication overuse patients with pre-existing primary headache develop this new type of headaches or significant worsening of their pre-existing headaches with medication overuse. It also reduces the reducing risk of developing MIOH. Using traditional migraine medications, 10 days per month, where I was trained, we used to say 6 days, or you're using analgesics that didn't exceed 15 days per month. I usually say 6 days a week. If you're using more than that, you're at risk for medication overuse. The treatment of choice is to stop using the medications. And you always tell my patients, as long as you're using generous amounts of NSAIDs or paracetamol, you will never get rid of your medication overuse. Now, MOH from overuse of medications increases the risk of chronic migraineurs. So around 70% of patients with chronic migraines were overusing acute care medications. Sorry, I just got to drink something. Overuse of triptans led to medication overuse headaches 1.7 years faster than other people. Nurtec, Rimidjapan, clinical value. So treatment with a CGRP receptor antagonist is thought to relieve migraine by blocking the CGRP-induced neurogenic vasodilation. You're halting the cascade of CGRP-induced neurogenic inflammation, and you're also inhibiting the central relay of exaggerated pain signals from the trigeminal nerve to the caudal trigeminal nucleus, as Dr. Joshi, very eloquently showed in his picture of the different receptors, different pathways of the trigeminal nerve system in the brainstem to the brain as well as peripherally. Freedom of pain at 2 hours in acute migraine. It's a sustained response from 2 to 48 hours. 63% of people taking Nurtec ODT experienced freedom from pain at 2 hours, and it was maintained to 48 hours. Now, Nurtec provides sustained pain relief from a migraine attack for up to 48 hours. Of those patients who achieved pain relief at 2 hours, 71% of them continued to experience sustained pain relief for 48 hours. And 86% of the Nurtec patients did not require any rescue medications in the first 24 hours versus 71% who were on placebo. Now, if we look at the quality of life, Rimidjapan has been shown societal benefit with reduction in absenteeism and increased productivity at work from significant improvements in presenteeism, translating into indirect cost saving for patient and healthcare workers. So absenteeism was down by 44%, presenteeism was increased by 43%. What does that equate to? You have 8 less days a month of being absent, which is great, given that you only have, 12 a year. You know, if you work at Saha, we have 12 absent days a year. So you're saving, you can't, if you were losing 8 days a month, you're gonna use your bank really quickly. And you have increased productivity time by 11 days per month. Now, if we look at Nurtec versus triptans, Nurtec has an early action, 60 to 90 minutes, its ability to function normal, pain relief, freedom from most bothersome symptom. As early as 15 minutes, you start seeing the effects. That's not statistically significant, but by 2 hours, it is statistically significant. 2-hour effect, as I just mentioned, a pain relief, you got freedom of the most bothersome symptom, ability to function normal, freedom of photophobia, as well as nausea. It's sustained from 24 to 48 hours. And you got the freedom of 2 to 24 hours, the sustained pain relief, sustained freedom of the most bothersome symptom, as well as no rescue medications. Now, if you look at triptans, 42% of patients receiving triptan did require a second dose at 2 hours. And we always say, and actually that's part of our prescribing, we always say, if you don't benefit with the first dose, take a second dose in 24 hours, because we routinely expect our triptan patients to use a second dose, and they frequently do. 67 to 82% of triptan users experience migraine recurrence within 24 hours. As opposed to the Rimidjapan group, they're getting freedom for almost 48 hours. 43% of people received with triptan have side effects, either the nausea, fatigue, rapid heart rate. It's not uncommon. A lot of my triptan patients will get this feeling of almost like their head is floating in space, they'll tell me. They just feel like their head is not connected to their body, or they feel spaced out. We know it's contraindicated in people with cardiovascular conditions. And switching to different triptans after initial treatment failure provides pain relief only in 25 to 50% of patients. Clinical attributes to recently approved treatments. So we've got now our 3 acute treatments. You've got Nurtec ODT, Rimidjapan. You've got Ubrogepant, which I do not have any experience using. We are starting to use it, but nobody yet has used it at Saha or at SSMC. Rayval, Lasmiditan. So if you want to look at the 3 drugs, Rimidjapan is one of the fastest drugs, within 15 minutes and is significant at 1 hour. And it's actually maintained for 48 hours. The only one that comes close to it is Lasmiditan, but you've got to keep in mind, if you work at SSMC, we're out a little bit, we're not in the city. So taking a medicine, getting your medicine from our hospital, you probably have to drive to it. And then all of a sudden you can't drive for the next 8 hours. Kind of gets a little hard. You know what I mean? So Nurtec ODT, Rimidjapan offers treatment for more migraines with fewer pills at a lower cost. You need less pills per month for migraineurs overall. Are there any treatment benefits for the small molecule CGRP receptor antagonist plus monoclonal antibodies in migraine therapy? In this article right here, there was, in conclusion, Rimidjapan may be effective for acute treatment during concomitant erinumab administration. I can tell you from my own practice, I actually combine monoclonal antibodies with a CGRP antagonist like Rimidjapan. And the idea, the way I was taught about, is that your monoclonal antibodies are large molecules. They tend to stay extracranially, or actually they don't cross the blood-brain barrier, while Rimidjapan is a small molecule. So it crosses the blood-brain barrier, gets into the brainstem. So in a way, the small molecule in combination with a large monoclonal antibody kind of goes into those nooks and crevices that the large CGRP antibody just can't get into. Now you just got to keep one thing in mind. If you combine a CGRP antagonist with a monoclonal antibody, you may get more side effects of the combination, but I don't really see it. But you just got to keep that in mind. Nurtec ODT offered early and sustained efficacy with acceptable tolerability. Significantly greater proportion of patients receiving Nurtec were free from pain of the most bothersome symptom versus placebo at 2 hours. Nurtec ODT provides significantly better freedom from pain at 1.5 hours. And Nurtec ODT gives you freedom from pain and reduced use of rescue medication. And it's very tolerable, very safe. It has a short half-life of only 11 hours, and the side effects are mainly nausea at around 2%. Various factors may drive the need for preventive treatments of migraines. Now, patients with migraine should be considered for preventive medications if the attacks are significantly interfering with their daily routines, if they experience more than 2 or more headache days per month based on the degree of disability, if they have contraindication or if they have contraindications, or if their acute treatment fails, or if they're experiencing tolerability issues with acute treatments, or if they're overusing other treatments. The goal of the preventive treatments of migraine, you want to reduce both the frequency or the severity of your headaches and have your patients have a low risk of medication overuse headaches. The current preventive therapies for migraines have limitations. You do have delayed efficacy. Before the benefit of oral preventive medications can be realized, you have to slowly titrate it. I mean, if you're using tricyclic antidepressants, you got to start off at a low dose of amitriptyline or nortriptyline, and you start off at 10 or 12.5 milligrams, and sometimes you need to get up to 75 milligrams, but that takes a while to get there. Poor tolerability. You've got adverse events. I'll go back to the tricyclics. You've got the clouding of your brain. You got the fatigability, depression. You got the anticholinergic, the dry mouth, the blurry vision, the urinary retention. If you're on Topamax, you're going to get drowsy. You're going to feel dumb. So that's something to keep in mind. So yes, it may work, and they do work. But then you got to worry about the side effects, and that's another balancing act. You have the high rate of treatment failures because people get bored of the side effects. 62% of patients will have side effects. And patient preference, fewer than 4% of patients prefer to receive monthly injections versus 63% would like to rather take a pill. So going back to that, courtesy of Pfizer. So now I'm going to talk about Rimidjapan, 75 milligrams for the prevention of migraines. This was another study. Eligibility criteria, very similar. You got to have onset before age of 50, greater than 4, less than 18 for migraines, attacks per month. So now we're a little bit above the 15, but still this is for, episodic and not chronic migraineurs. They were randomized 1-to-1, and the open label extension was looked at for 52 weeks. If you look at the demographics of the treatment arm and the placebo, very similar. You had a total of 741 patients. So how did Rimidjapan do? You actually had, if you look at the change in monthly migraine days of the Rimidjapan group versus the placebo, there was a reduction in monthly migraine days, and that was statistically significant. Now, Rimidjapan, 75 milligram for the prevention of migraine. Whether you notice right here, what was the percentage of change from the observational period? Now you'll notice in the placebo arm, it's 9.4% in week 1, 30%, or you had a 30% change in the first week. So, I'm sorry. Worked fast. Second week was sustained. Third week and fourth week, sustained ability. So that's a good thing. Now, this is an interesting slide. A lot of our patients, when I'm talking to my patients, بيسألوني هيدا علاج ولا هيدا مسكن? Now, when we think of analgesics, it's usually more of a symptomatic therapy. You take it, you get better. You don't take it, your disease or your pain comes back. Now, interesting enough, we think if you would think of like acute migraine therapies, you would think of it as a symptomatic therapy. You take it, you stop your headaches, and you're good to go. But what's interesting is with long-term use of rimegepant, you're actually decreasing the quality and the intensity of the headache. So it does something different. It doesn't just fix the symptoms. It doesn't just reduce the headaches. It actually works on the headaches per se, or works on the pathway. So people who are taking this medication frequently actually get less migraine headaches per month. It appears to work on a different, the mechanism is interesting. When you look at a network meta-analysis, it suggests that rimegepant has a comparable efficacy to current preventive monoclonal antibodies. Now, this is, again, a meta-analysis. This is not a head-to-head trial, so you got to take this with a grain of salt. But when you look at rimegepant versus erinumab, rimegepant versus galcanezumab, rimegepant versus frenanizumab, 2 doses, it doesn't appear to have anything favoring one versus the other. But again, you got to take this information with a grain of salt, because this was not a head-to-head trial. Nurtec clinical added value as a preventive treatment for migraines. It does not have a long half-life. If you look at that versus of 11 hours versus for the CGRP biologic, the drug is out of your body. The drug is out of your body in 33 hours, as opposed to the monoclonal antibodies at 6 months. Nurtec clinical added value is a preventive treatment for migraines. For preventive pharmaceutical treatments, most patients prefer a pill, 52%, versus an injection over only 9% or 4%. There were no unexpected or serious safety issues were noted. My timer stopped. Wait, oh, there we go. There was no unexpected or serious safety issues that were noted. Safety and tolerability was similar to placebo. Constipation reported up to 40% of people receiving the CGRP antibodies. We got to keep that in mind. Evidence of wearing off of effectiveness of the monoclonal antibodies. We tend to see this at end of month dosing, but with rimegepant, it's not that common with that. And it's not contraindicated in people with cardiovascular disease. Nurtec clinical value as a preventive treatment for migraine. Yeah, I didn't, this slide I'll just skip. Preventive treatment, that is also a little redundant, take that back. So what was the final effect? Study 305 showed that rimegepant 75 milligrams was effective for episodic migraine prevention in adults with a tolerability similar to placebo. 75 milligrams every other day was significantly different from placebo, as I showed you on the primary endpoints on change in the mean and the number of migraine days per month. And I showed you if you were to take it as routinely, you actually get less headache days later on. 75 milligrams showed a benefit in a proportion of patients with greater than 50% reduction in the mean number of moderate to severe migraine days per month in the last 4 weeks of a 12-week double-blinded treatment phase. And a greater reduction in migraine frequency was seen in the 75 milligram group compared to placebo at 3 months. And that's what I was talking about right now. There was no unexpected or serious safety issues that were noted, and tolerability was similar to that of placebo. With that, thank you very much. I'm a little bit finished earlier, but thank you. Can't hear you, Dr. Zakaria.
Thank you, Ahmed. Sorry, it was on mute. Thank you. It was very nice lecture. So now we are going to get into the question and answer. Some of those questions were already answered by Dr. Joshi, but we are going to ask them again for the sake of other participants. Ahmed, you are with us?
Yep.
Yeah, everyone.
Yep, I'm with you.
So I have my first question is for Dr. Joshi. We are having tendency, Ahmed and myself, and other neurologists here in Abu Dhabi, to use CGRP antagonists as a first-line treatment in patient with migraine headache, a naive patient. What is your personal experience and input about it?
About using what? I'm sorry.
CGRP antagonist as a
Uh-huh.
first-line treatment.
Sure. A great presentation, Ahmed. That was wonderful.
Thank you. Thank you.
I typically, there are limitations depending on where you are using CGRP as a first line because of insurance. Most payers will require you to trial and fail at least one or two different classes of types of triptans before you can get to a GPAN for acute treatment. But certainly, if that's not an issue, I think it's certainly an option for a patient to use a GPAN for acute treatment. Yes.
Ahmad, can I know your input about it?
I think one of the things is, Dr. Zakaria, for us is that, yes, GPANs do work. And, the first line, the older medicines do work as well. So I don't think, they work. But one of the problems is whether, I like using tricyclics. I was trained in my residency program. Tricyclics are a great first line to use for, preventive migraines. But the problem are the side effects of these medications, and there's a lot of them. The other thing is, you got to titrate it, so it does take time to get to. You got the triptans, you got the cardiovascular problems that we worry about. The GPANs, they're safe. They're safe. They're effective. It's one dose. We don't have to titrate it. They work quickly and effectively. So I think, as Dr. Joshi said, if the insurance is willing to cover it, it's a very safe and effective medication to use. And that's why and that's why I think both of us, we tend to use it sometimes as first line, because it is safe, it is effective, and we do see good results.
Yeah, absolutely. Very good result so far. So we'll start with the question of the audience and the participant. Guys, it's for both of you, whoever. Is food counting ginger effect on drug treatment migraine by enhance or decrease? Food counting ginger effect.
Not sure what the question is.
Yeah.
Not clear. Food, if whoever sent us this question, it will be more beneficial if she or he can send it again.
I can make some general comments on food, though. I think when it comes to food, there are some foods that are known triggers. For example, we'll typically tell our patients to avoid foods that contain nitrates or sometimes even monosodium glutamate. But apart from that, I think it's important patients don't skip meals, right? So sometimes patients do these diets and keto diets, and they're drinking only water for the whole day or skipping lunch. For migraine patients, it's very important to have some protein in the morning and not skip meals, as the migraine brain doesn't like change. Just like if your thyroid level is off, it can be a source of migraine frequency. If your sugar level is off, it can be a source of migraine frequency. So, with regards to alcohol, red wine or sometimes tannins or sulfites can be a trigger for some patients. And so I think in terms of food, I would stay away from anything that's nitrates. Now, the other part of this is that some people, there was another question about chocolate, right? And for some people, it can be a trigger. There are some ingredients in chocolate that could be a trigger for some patients. But if we take a step back and look at the different phases of a migraine, before the aura phase, before the headache phase, there's a prodrome phase, which is mediated by the hypothalamus. So, part of the theory of migraine pathophysiology, not only the brainstem, but more and more recently, in particular, talked by Dr. Rami Bernstein out of Beth Israel in Harvard, is that there's early hypothalamic activation. In hypothalamus, you have, yawning a lot, peeing a lot, mood changes, neck stiffness, and craving salty or sweet foods. So for some of these patients, the craving of a chocolate could be part of a prodrome phase, an early warning sign that the migraine is coming. And then they eat the chocolate and they assume it's a causal factor, but it could be an early warning sign.
Very interesting. Very, very interesting.
Just to emphasize Dr. Joshi's point about eating. Ramadan's coming up this month, and we see a lot of headaches due to fasting. So stay hydrated, guys. make sure you have your suhoor, eat the food, and it's almost the migraines and headaches increase dramatically during Ramadan, everyone.
So if you can, have maybe some protein in the morning so that stays in your system for longer,
Yes.
But yes, very important.
By the way, there is any number of hours known where we have to avoid, exceeding those number of hours so we don't have migraine? Shall we tell the patient that she or he has to eat every 6 hours or 7 hours or 8 hours?
I think that, when people think you have to eat 3 times a day, 3 meals, they don't necessarily have to have big meals. They could also have a snack, as long as it's enough to keep the sugar level normal. If you're already saying you're hungry, then it's too late because that's the part of the brain telling you, the hunger. So I would say, if you're not complaining about hunger, then that works for you.
Okay. We have a question about lasmiditan. Does any adjustment in renal failure, do you have any parental form available? And is it used as a prophylaxis before attack?
So I'm not aware of any parenteral available. I think that there was a study done looking at that. So obviously, if someone has renal failure, it's you have to use caution using any medications. There's no data on using it as preventive. It's used for acute treatment during a migraine attack, and you have to be cautious only because there's a potential for sometimes sedation or dizziness. So the recommendation is to not drive until 8 hours after use. So when I say driving, it also means operating any kind of machinery or things like that. But the important thing to know that it was also studied within 4 hours of use. So if let's say you have a migraine and it started 4 hours ago, there is data to suggest that if you take the medication within 4 hours, it will still be effective for you. So this gives you the opportunity of taking the medication, let's say, when you're at home.
Okay. We had a very good, I'm trying to find, I got this very interesting question from a neurologist. Thank you for your presentation. When it comes to acute migraine medication, let's take an example of lasmiditan. As a neurologist and having migraine personally, why shall I take these drugs which improve my attack but brings to me another disability, not driving for hours due to dizziness? I would like to understand this rationale. Thank you for your answers.
Right. Certainly, I think that, wouldn't be your first choice, right? I mean, there are other options that you can take that don't cause that adverse reaction. And I would say that if you've tried some of these other options, and some of them that were presented today, including rimegepant, and that's efficacious for you without any adverse reactions, then you don't have to go to the other choices, right? But let's say you're not getting efficacy from something and you want to try something and it is causing some benefit for you. You have some flexibility of when you can dose that medication. But remember, not everybody has the adverse reactions, right? If you look at the package insert, the number of patients who had severe dizziness was actually, I want to say, less than 1% had severe dizziness. So you might fit into the category of patients that don't have significant dizziness. I think about 11 to 16%, I could be wrong, had moderate amount of dizziness. So it's possible that you don't experience that. And, certainly it doesn't have to be your first choice. There are certainly other options, such as triptans or gepants that can be tried that, may work for you without having adverse reactions.
Is there any treatment for this dizziness? Is there any way to avoid it?
Well, the medication is available in different doses, so you could try to do a lower dose. And once again, you could also take it at bedtime, right? You can take it, yeah.
Ahmad, do you have any comment?
No, I agree, Dr. Joshi. I mean, the problem is, in places where like Abu Dhabi, UAE, it's a very driving dependent country and culture. I was from Detroit, so again, same thing, the Motor City. It gets hard if there's no good public transportation. It would be hard. It's almost like a death sentence to take a medicine where you can't drive or can't function. So maybe in Europe, they don't use cars as much in some places. You could say maybe, it wouldn't matter with me, so I wouldn't need it. Or if you lived in a big city with a good public transportation. But, again, first choice is to look for something where you don't have this side effect. And if all else fails and that's the only thing left, you could try a lower dose.
Okay, two questions. The first one, why only women mostly have migraine? Is there any specific reason?
You can start,
Right.
Isaiah.
Why do women? I'm gonna, here we go. We got to blame the estrogen. This has to be the estrogen.
It's
No, I mean,
great.
I think, that was an interesting thing, when I was in residency, every time, when you look at whether it's autoimmune disorders or migraine, why is it women versus men? The easy answer has to be estrogen, but we do know that estrogen actually does play a role where you do get catamenial migraines. There are people that are prone to migraine when their estrogen levels change in their body right before and during menstrual cycle. So estrogen is a factor for causing migraines. And we know that oral contraceptive pills can trigger migraines in select patients. So I think estrogen's probably a role, but I don't think it's the only role, because how do you explain it in men? Dr. Joshi, you want to help on that one?
No, I agree. I think there's some theories that it could be a mitochondrial disorder migraines, which are, more common in women. So, I think that the estrogen plays a key role in migraine pathophysiology. And so this is probably the main reason why it's more common in women.
What is the probable cause of migraine for children?
I think that if there's no secondary cause, the cause is the same as it is in adults. I think one of the problems is that a lot of these children or adolescents go through life without a diagnosis of migraines and without adequate treatment. As you know, that there are not enough pediatric treatments available. More studies need to be done. And what we wind up doing is using adult medications in lower doses. But, infantile colic has been associated with developing into migraines later on. Cyclic vomiting syndrome has been associated with developing migraines later on. And I frequently ask questions about, was there any childhood car motion sickness? So, patients will go through their life with a diagnosis of sinus disorder. They see an ENT, a dentist. So I think, it is the same disorder. And, data shows that boys will have migraines first at age 12, and girls will have it at age 13. But because of women and hormones, it's more prominent and becomes more debilitating in women as they get older and the hormonal cycles occur and changes. So I certainly think it's the same disease, but unfortunately underdiagnosed and undertreated in a pediatric population.
True.
Any relationship between diabetes and migraine?
Well, if your hemoglobin A1C is off, it can be a trigger for increased frequency. Like I said, the brain doesn't like change, right? So if your thyroid level is off, if your sugar levels are off, it can be problematic. Interestingly enough, topiramate was originally studied as a diabetes medication, in research many, many decades ago. So that is the connection with diabetes is, the brain doesn't like change.
Sorry, you said topiramate was studied initially for diabetes?
Originally, many, many decades ago, in a lab research setting, it had some anti-glucose properties. Yes.
Why does it have an effect on glucose?
I think it was being studied for that, and we know that it does have an effect on weight loss.
Could it be due to the weight loss? It might be beneficial for a patient with diabetes.
I think weight loss in general is beneficial for anybody with diabetes. Absolutely. Yeah.
Yeah, probably this is the case. Well, this is always the same question, but I guess we are going to say, is it safe with pregnancy and lactation? I assume they are talking about CGRP antagonist. I think the answer is no. There is no indication. I mean, we don't have enough information. I mean, and it is contraindicated to be used in pregnancy and lactation. Dr. Ahmed, Dr. Joshi.
Just to give you an update, so fairly recently, rimegepant was studied with lactation, and I think I presented that data in my slide, saying that only less than 1% is found in breast milk. So I think that's fairly okay to use based on that information. Regarding the monoclonal antibodies, they are the half-life is generally a month or so. So it takes about 5 months for it to be cleared from your system. There is, Framazimab, slightly different in its molecule, has a 2 delta group, which it seems to make it less cross over the placental tissue. So, but in general, if I have a patient that is planning on pregnancy, I currently do not use a GPAD or plan to titrate off the GPADs. I'm sorry, to titrate off the monoclonal antibodies.
So in your practice, in your daily practice, if a patient is planning, and a woman with childbearing age, you recommend to use rimageptan because you can get rid of it faster than monoclonal antibody, right?
Well, the monoclonal antibodies are used for prevention, and rimagepant is used for both acute and prevention. But the GPADs have a shorter half-life. So, you look at the half-life, it's 11 hours or so. And 5 of those half-lives after that, it's out of your system. So certainly it's easier to come off of than a monoclonal antibody.
So 1 month is enough for GPAD versus 5 to 6 months with monoclonal antibody?
Roughly, yes.
Okay. Do you usually advise patients to take GPADs with metoclopramide to avoid further nausea?
I really haven't seen that much nausea.
Yeah.
Ahmed, would you, Dr. Shahid, Satila, sorry, would you see that?
I probably only seen a couple patients with nausea, but it's nothing that would make the patient not take it. I mean, every now and then it's like they get a little nauseous, but what's from the migraine and what's from the GPAN, and
Exactly.
usually the benefit of the medicine outweighs any side effects. So they're usually happy with it.
I have an interesting question. Can extreme weather change cause migraine attacks?
We know that, well, I don't know about weather change, but we do know that people that are exposed to bright lights, bright sunlight, they can get, they can trigger their migraines. And it's not uncommon in Abu Dhabi in the summertime. A lot of my patients will complain that their headaches do get worse. And there is some evidence with, the photic response. So if the weather change is related to that, I could say maybe.
Yeah,
Sunlight.
Yeah,
complaint, it's with weather changes, more the barometric pressure changes, right? So sometimes the barometric pressure changes when there's a low pressure system coming. This can be a trigger. Patients are very sensitive to some of this, to the point where some of the weather channel stations will actually, they have in their apps, they put down migraine index, and they put the index is going to go high, depending on whether the barometric pressure changing is going down. So it's not necessarily weather changes, it's the barometric pressure changes that can be a trigger for a lot of migraine patients. And also for some patients, I've seen them complain about when they go from the air conditioned room to the heat and back, the humidity changes can be a trigger for them as well.
Yeah.
another interesting question. Which migraine secondary to fibromuscular dysplasia, can we use Japan?
I
I'm not
don't know
sure
of
if
any kinds of.
fibromuscular dysplasia has been associated with migraine, as far as I know. Any of
I'm
you
not
guys?
aware of any contraindications.
No.
So yeah.
But usually, in general, fibromuscular dysplasia is not associated with migraine more than the general population. Do you agree with this?
I think there may be something there, once again, these patients were not included in the clinical trial. Just like patients with Ehlers-Danlos, POTS, and there's a higher comorbidity with some patients with these kinds of connective tissue or other diseases. So, but I wouldn't attribute causality though.
Yeah.
Okay. Okay. Is there any other research molecule apart from rimageptan in tablet form for the treatment of migraine? You mentioned about the nasal form that is being under investigation now. Is there any tablets that might be coming any soon?
So, I mean, ubrogepant is a tablet form. That's another GPAD. Yeah.
Yeah. But I'm talking about prophylaxis.
So atogepant is a tablet form. The GPAD is for prophylaxis.
Okay. And Okay, so, and then Ahmed, there was a question for probably for is rimageptan available as an over-the-counter medication?
No, you need a prescription for Japan and the UAE.
Okay, this was mainly the questions that were asked by the audience. I think we are gonna conclude right here. Maya, you are with us?
Yes, doctor.
Hi, Maya.
Hello. So let us conclude the session. So let me first thank our amazing moderator for tonight, Dr. Zakaria Ammash. Thank you for being with us and moderating and accommodating all the questions from our audience. Thank you so much. Thank you for our esteemed speaker, Dr. Joshi, who joined us from the USA despite the difference in time. Dr. Shetila, also, thank you for accepting our invitation despite your busy schedule. Also, let me thank Pfizer, our sponsor, and and remind you that all these masterclass are being organized in collaboration with the Association of Migraine Disorder. So thank you for a fruitful and a very great collaboration. So before leaving you, I would like to remind you that you will receive your certificate of attendance within 1 week from today by email. Also, if you missed any of the session and you would like to revisit this class or any other class, you can visit our IVPN library where all the recordings are posted within 1 week from today. And finally, I would like to always remind you to follow our social media platforms and our LinkedIn page where we will post all our upcoming activity. Stay tuned for more activities in migraine and other neurological disorder. And until I see you again, stay safe. Have a good night.
Good night, everyone.
Thank you. Thank you.
Thank you, everyone.
Thank you, doctors.